I'm ready, sir.
Okay, go on then. There's a picture here. The gentleman came to A&E, and apparently he was involved in a situation where he was pushed into the wall by a heavy vehicle. So there was a wall in front of him, and the car was behind him. So he's just turned it, and this is his X-ray. So do you want to start talking about this?
Yes, sir. First of all, I will follow the TLS protocol.
Very good.
And I will exclude other other systemic injuries, and by considering that this is an isolated injury and patient is then we'll see that either the patient is stable or unstable. Will go accordingly. Number one. Then
okay, so the easiest way to say this is
assuming that this
after I have stabilized the patient with the ATLS protocol, assuming this is an isolated injury, I will tell you how I manage this patient. Okay, so it covers every option. So you can say that I've done an ATLS protocol and this is an isolated. So assuming that you've done the ATLS and this is an isolated injury, what do you see on the X-ray?
Okay, the X-ray show the most obvious finding is the widening of the symphysis pubis. That looks more than 2.5 centimeter, means it is APC type 3 according to Young and Burgess.
Good.
And I will initially apply the pelvic binder.
Okay, so what type is this? Is it an open book fracture, isn't it? That's what it's called, yeah?
It is, yes, sir. It is an open book fracture. On the classification, it is APC3, as I already mentioned.
Okay. So as part of your management of the ATLS protocol, this comes under C, isn't it?
Yes, sir, APC3.
So what are you going to do with this?
Sir, need to fix it.
So what? No fixing first of all.
Sir, first of all, apply the pelvic binder.
Good. And if you haven't got a pelvic binder, what are you going to do?
To reduce the volume.
Yeah, if you haven't got a pelvic binder, what are you going to do?
Sorry, sir?
If you haven't got a pelvic binder, what are you going to do?
Sir, if no pelvic binder, then I can use anything. Bed sheet, patient's belt.
You can have a draw sheet, or you can cross the patient's legs.
Yes, sir.
By doing that, it will close the book for you. Okay?
Yes, sir. Yes,
so which is worse, fractures at the front or opening at the front or opening at the back?
Opening at the back, sir.
Why is that?
Sir, because this makes it unstable. Because if the book is open from one side, it can be closed. But
okay, so assuming that this is not open, but it's open at the back, what are you going to do then?
So then I will apply the skeletal traction.
Great. Skeletal traction will be only applied if it's a vertical force and it's gone up or down, isn't it?
And sir,
we'll still use the binder.
We'll check the availability of C-clamp.
You can do that, but you can still use the binder, or you can still cross the legs. But the big problem is they will start still bleed because you need to have compression to stop the bleeding. So how will you find if there is a problem with bleeding? How would you know there's a problem with bleeding with these patients?
Sir, because most of the bleeding source is from the venous plexus.
Yes.
And if my patient does not get stable with the pelvic binder, then we'll consider for the external fixation.
Before that? Before the external fixation, what are you going to do? You need to find out the source of your bleeding, isn't it? And how are you going to do that?
Yes, sir. Unless it is a clear-cut source is arterial or some external source.
So what are you going to do?
I will consider, sir,
an angiogram.
An angiogram.
Yes, and you can embolize the vessel at the same time, so you don't have to later on.
Exactly, sir.
You can stabilize them by putting an embolization from an angiogram. Okay, most common things we do in this part of the world is we cross the legs or put a binder or a draw sheet, close it, and then if it is still unstable, i.e. the patient C is not settling down in the triage, then we will do what is called an arterial angiogram, and we will embolize the vessel that's bleeding. That most of the time sorts it out, and then you can go forward and later do something with it. Okay, so remember that a vertical force, when they fall up and down, you can use traction with a binder. If it's an open book, you use a traction. If it's open at the back, you will use a binder. And if you have various other classification, you can treat accordingly. But most common is you just close the book by putting a binder or crossing the legs. Okay.
Okay.
Who's next? Who wants to go next? So this is a 59-year-old who has come to A&E after falling from the steps, and he is unstable with his blood supply and vascular part of it, and it is an open fracture. Okay, so you can see it's an open fracture. So who wants to go have a go next? One, guys, I mean, you have to, this is exam time. You should be ready to go rather than me asking who wants to go next.
Or shall I continue?
If you, I mean, nobody else is going to learn, so somebody needs to participate. Otherwise, there's no point just turning up for listening to other people.
Yes, sir. Yes, sir. I am Dr. Asad.
So what's this?
Sir, it is distal femur spiral fracture. Looks osteolysis as well.
There's no osteolysis, yeah. So it's a trauma table. So on the trauma table, you get trauma. Okay, so it's a stable periprosthetic fracture, which shows a distal third of the femur in fractures. And it's an open injury, which I told you. And the blood supply or the C is not being controlled. So what are you going to do next?
Sir, I will...
Very simple. You will straighten the leg, isn't it?
Yes, sir. I will
you straighten the leg and either put a plaster on it or put traction on it. Okay. If it's an open fracture, what are you going to do next?
Sir, if it is open fracture, I will cover the wound with sterile dressing. Will give analgesics and tetanus prophylaxis.
Okay. So do you know the BOA protocol for the open fractures? You have to take a picture first, take a swab of the wound, clean and tidy it, and then close it. Apply the tetanus toxoid, antibiotics, straighten the legs, and then come back again to revisit this, okay? You must also remember that open fractures are classified after debridement, not before debridement. So a 1, maybe a 2 or a 3.
Okay, sir.
Okay, so now that you have done this, do you know of a word? What is damage control orthopedics? Does anybody know what damage control orthopedics is?
Yes, sir. Yes, sir.
Yes, sir.
Go on, tell me about damage control orthopedics.
Sir, we temporarily stabilize the patient, avoiding the second hit to the patient.
So you need to tell me 3 things. What were you going to do? You're going to span, plan, and scan. Yes?
Yes, sir.
What does that mean?
Sir, we first temporarily stabilize the fracture, span, then we go for the scanning, like if we need CT scan or like this.
But not scanning, but x-rays and various other things, yeah? And then you plan what you want to do with it.
Plan, yes, sir. Definitive plan, yes.
Okay, so what's the difference between a Gustillo-Anderson classification and a Teixeira classification? So what's a Gustillo-Anderson classification?
So Gustillo-Anderson has been classified on the basis of size of wound, contamination, and energy of trauma. So it is 1, 2, 3. 1 is less than 1 centimeter and with no contamination. 2 is 1 to 10 centimeter with minimal contamination, and 3 is further divided into A, B, C.
Okay.
So A has got good soft tissue coverage. B needs soft tissue coverage like flap, and C is associated with vascular injury.
Vascular or neurological injury, yeah?
Yes, sir. Vascular and neurological.
You must specify it very clearly in the exam is that this classification is done after debridement is done. Okay? Not before that, because a 1 may become a 2, or a 2 may become a 3, depending on how much skin you take out to clean and tidy it up. Okay.
Yes,
so what is the Teixeira classification then?
So Teixeira classification, I don't remember exactly.
So it's a classification where the bone's not broken, but there is soft tissue injury. 1 is bruising, 2 is hematoma formation and ecchymosis, and 3 becomes detachment of skin, and 4 is when there is a complete devascularization of the skin. Okay, so if your bone is not broken, but your skin is also having a big insult, and it could be a problem, and therefore you need to make sure that you know what's happening around it, especially if you have old ladies who come in with big hematomas on their shin. If you're not careful, that hematoma will deglove the skin, and therefore they will end up with problems, yeah? So what about this?
Sir.
Again, this is an open fracture. How are you going to manage this? Let's assume this is a closed fracture, okay? Somebody else wants to have a go?
Hello. Yes, sir.
Go on then.
Okay. So first of all, I will follow the ATLS protocol.
Okay.
Number
so
one.
In the exam, you must say that assuming that this patient is charged with the ADLS, it has been stabilized, and this is an isolated injury, my plan of management will be. You have to say this. It is like your,
yes,
whatever you get a party political broadcast. This is the first thing you have to say every time you start with a trauma patient. Every time. Okay.
Okay, sir. So what I plan, I will say that initially I will follow the ATLS protocol. Then we'll say that they're considering that this is an isolated injury, isolated closed injury with the intact neurovascular status.
Yes.
Then I will go for this.
Okay. So how are you going to manage this? This patient is stable. There's nothing wrong with this patient. He has just come to you to see for his further management. You have stabilized him. ATLS is stable, and this is an isolated injury. So what are your plan of management for this particular type of patient?
First of all, I will get other X-rays, especially
like what you want to have. The joint above is normal and joint below is normal. What else?
Joint above and the joint below. If it is normal, then we'll see the skin conditions. Is it open or closed?
It's fine. It's closed injury. There's some hematoma, but it's a closed injury.
If it's skin condition, then we'll look for the any evidence of compartment syndrome.
Very good, but there is no compartment syndrome here.
If there is no compartment syndrome, then take patient's blood sample for the cross match for the fitness purpose.
But you would have done that in your ATLS triage, isn't it? So you don't need to say things that you've already done in your ATLS triage.
Yes, sir.
So your plan of management is either X-fix, intermedullary fixation, or plating. Okay, so which one would you like to do?
Sir, I would like to do internal fixation with the intermedullary nail.
Okay, why is that?
Sir, because of this implant is a load sharing implant, so the patient can be mobilized earlier, number one. Number two, patient can early weight bear with that implant.
So every patient you put a nail in can weight bear early?
So not every.
So how do you decide who can weight bear early?
Sir, according to the fracture pattern.
Okay, so what is that called? There is a name for that.
Sir, degree of comminution, I will look for the...
No, there's another name. There's a basic general name for it. It's called the working length, isn't it? So what's the working length of a tibial nail?
Okay, sir. I'm sorry, I don't have an
idea. So the working length of any implant you put in is where the bone is not in contact. In a tibia and a femur or a hollow bone, you have two working lengths, one in rotation and one in flexion. Mm-hmm. Okay? So in rotation, when the bone is not in contact with the nail, that will be the two bolts you put in, the proximal and distal locking bolts. In flexion, where there is broken or comminution, that will be causing no contact, and therefore they will be able to have a shorter working length. Right? Working length is inversely proportional to union. So if you have to weight bear them, the working length has to be small, both in flexion and rotation, and you have to have a bolt of more than 6 millimeters, which means a 12 millimeter nail. Because anything less than 12 millimeter, your bolt is 5 millimeters that you lock proximal and distally. But if you put a 5 millimeter bolt and you have a big working length, if you weight bear them, you'll be in trouble because your bolt and your metal will not hold it like it. So not every nail you can walk. You need to be sure what you say before you realize what you're saying. Okay, but yes, it's a good thing we're not talking about working length and all that kind of stuff. Okay, so you would like to nail this, which is good because the working length would be smaller. It will be easier, and plus it is a load sharing device. Okay, so if you ream this nail from inside, what happens? Your periosteum is gone. By reaming, what happens then?
There may be the chances of sir, you're asking for the reaming complications?
Yeah, you're going to put a tibial nail, you're going to ream it, isn't it? You can't just stick a nail into it, isn't it? Unless you ream it, it won't heal very well, isn't it? So what you need to be 1.5 centimeter, 1.5 millimeter above the size you put in, isn't it? So what if you have a periosteal, problem here because it's fractured,
sir,
and you ream it, what's going to happen?
And yes, sir. If it is open fracture, that periosteum is disrupted because there are two blood supplies. One is from the periosteum, other one is endosteal. So with the reaming,
that's why I asked you, isn't it? You're going to ruin the endosteal nerve blood supply also. The periosteal one is gone now, isn't it?
Definitely, sir. Then
so what's the benefit of reaming?
Sir, Sir, benefit number one of the reaming is number one, you can put a more diameter nail, more fitting. Number
You can
second
put a
is
bigger diameter nail, so you can have a bigger bolt, so you can weight bear them.
bigger bones.
What else is the benefit of
for
reaming?
Stability.
What's the other benefit? There's two more.
Other benefit is from the reaming area, we have reamer aspirant. Reamer aspirant comes at the fracture site, and that will
bone
enhance the
grafted.
feeling.
They will bone
Yes,
graft it.
Act as a bone graft.
The reaming bone grafts it.
Yes,
okay.
Sir. Reaming bone graft.
And that was the third one.
Sir, one benefit is you can do it in a closed manner. You should not open the fracture site.
People pass metals, plates without actually opening it, but percutaneously, like a meepo thing, isn't it? Yeah. Yes, you can do a closed landing, but the other thing also is hyperemia. When you ream them, the whole intramedullary canal becomes hyperemic, which is conducive to healing. Okay.
Yes.
So stability, hyperemia, and bone grafting.
And bone
grafting. The benefits of intramedullary nailing and reaming. The problem, for lack of a better word, uska nuksan ye hai ki you take the blood supply industrial
blood supply
is gone. Yeah, so you need to know these things when you're talking about nailings. Okay.
Yes.
Okay. So the other option is you can manage this in plaster. Can you manage this in plaster?
We can manage, but the fracture pattern, the geometry of fracture looks unstable.
Yeah, well, you can manage in plaster. There's a big, huge book written by, and a lot of papers done by, what was that chap who did Sarmiento? He did all his patients manage non-operatively with plasters, isn't it? As long as you can justify your answer, you can say, well, you can say that people have managed this non-operatively in plasters, and there's a big series from Sarmiento on tibial fractures with plaster management. But the problem is you have to be very vigilant. You have to see them very quickly, not 2 weeks, 3 weeks, but quickly to make sure that if they move, you can sort them out by wedging them or strengthening the plaster or something like that. You can do corrections, but you can manage this in plaster because that's what Sarmiento did. All his patients were managed in plasters. Okay. So if you say something that the examiner is not happy, then you make sure you have a evidence or reference for it to tell them this is where you read it and this is what it says. Like, okay, well, this was managed with an X-fix. So what's wrong here?
So number one, principles of X-fix has been violated.
How? Yes, you're correct, but how?
Because the first in the pin that has the Sean's pin that has been placed in the distal part, the one which is near to the fracture site looks fine because it should be at the area of 2 to 3 centimeters. But in the proximal one, this one is more proximal. That makes the fracture
so that's the one
unstable.
thing. Second,
and
so it's not reduced properly. There's still rotation element.
Yes, sir. Second thing is fracture is not reduced.
Yeah, so if you haven't reduced the fracture in the next fix, this is a disaster non-union, isn't it?
Yes, sir. And third thing is that in proximal part, we have space. We can apply multiple shunts for the stability purpose, but he hasn't.
Yeah, so this is probably was an open fracture, and they've done the spanning, isn't it? Like held it together, come back to more permanent solution for it. Okay, but with the next fix, okay, how does a bone become from soft tissue to cartilage to become fibrous non-union to become calcium or callus? How does that take place? Do you know that principle? So there's going to be hematoma, and the hematoma has got 3 options. It can be a fibrous tissue, cartilage, or bone. How does it take that path?
Sir, it depends upon the mobility at the fracture site.
Very good. What is that called?
Sir, if the fracture site is stable and it is not mobile, then a callus is formed.
How? So the mobility to check karna nahi aata na, so there must be some way of the body to assess that. How?
Sir, micromotions jo hoti hain fracture site.
It's called relative strain. Okay.
Yes, sir.
The mobility of the fracture compared to the initial size is called relative strain. And if the relative strain is less, then there is signal for calcification and it becomes calcified. Okay, yes, exactly what you said. Yes, more movement, non-union or fibrous union. But scientifically, it is called relative strain. Okay?
Okay,
that is why ulna does not unite, but a femur and tibia unites very easily. Because the movement at the ulna is too much for it. Okay, yes, so I think this is what it's okay. What is this now? Who's going to have a go?
Mr. Dr. Gulfam from Indus.
Yeah, go on then.
It's a X-ray of elbow of a skeletally immature patient showing Gardner 3
Skeletally
supracondylar.
immature. So look at this radial head. Okay, look at this radial head.
Immature.
It has to be a child, isn't it? A supracondylar fracture is always in a child. Very unusual to have something like that in an adult, yeah?
Yes.
So what type of injury is this?
It's a Gardner type 3.
Okay, so now you said, who was Gartland? Why can't you just say it's an extension type of injury?
Yes, sir.
It's just totally displaced and unstable. Okay, you
Yeah,
must say
okay.
things that you can defend yourself in the exam. If you tell me, if I'm sitting in the exam, you tell me this is a Gartland 3, my next question will be who was Gartland? Unless you
Okay.
know who's Gartland, I would not name mentions unless somebody asks you. You can say this is an extension type of injury which is unstable, offended, and it is a supracondylar fracture in a child, isn't it? So what is the problem with these kind of injuries?
The problem is that there is a high risk of brachial artery injury with
Very
these types
good.
of fractures.
So how will you
And
check that?
I will see the radial and ulnar arteries, and will see the capillary refill.
Very good. So if the capillary refill is okay, but you can't feel the radial or the other artery, ulnar artery, what are you going to do next?
I will reduce the fracture and then
Before you
reassess
say
the.
when are you going to reduce the fracture? That's the next question.
I will temporarily split in the emergency, and then will shift the patient to the
Is that
OR
an
for.
acceptable answer in Pakistan? Because in England, if you tell me that you will do it in the emergency, I will ask you to come back next time. Is it an acceptable answer in Pakistan? I don't know. That's why I'm asking. Is it an acceptable answer in Pakistan to say that you will reduce this in the E&E?
No, so I will not reduce it. I will temporarily splint in the emergency and will
Very
shift
good,
the patient to OR. I will shift the patient to OR for definitive treatment.
Okay. So there are certain things you must remember. I'm not sure what happens in Pakistan, but if you're working in this part of the world, the exams in this part of the world is a bit different. First of all, is you have to say you have to stabilize this in a plaster. You will fix this or try to fix this in the next available plan list, which means there are people around you who know what they're doing. You don't want to do it in the middle of 3 o'clock in the morning when you have nobody around you to tell you what's happening and you end up with more disasters. This is a child, it's not an adult, Mike, okay? So we'll relieve the pain, you will splint the patient and do it the next possible available list where people are around you. If this patient has or have got a problem with vascularity, then you will have to have a vascular surgeon on standby when you're doing this, because if you don't have a vascular surgeon and you open this and the artery starts spurting, you are in trouble then, isn't it? Okay. How
Yes,
do you
okay.
reduce these fractures?
I will use the manual. It's called. I will see in the C-arm. I will reduce from the first in the AP view, and then we'll see the lateral view.
Okay. So do you think you will be able to reduce this fracture easily or with difficulty?
So it seems that it will be difficult, and will.
Why would it be difficult?
Because it's displaced and it may have a soft tissue interposition.
Something else is wrong here, isn't it? The periosteum is gone. You normally need a periosteum to hinge it to allow the fracture to be reduced. Isn't that right?
Yes, it's
If the periosteum is not there, it will be very difficult to reduce it, and even if you reduce it, it will be very difficult to maintain it.
Yes, sir.
Okay. So what other things you need to know? What can you do if you feel that it is a difficult reduction? What are you going to do next? You always try to open it first. Yeah. And if it doesn't work, what are you going to do?
I will open the fracture.
Where? From what side?
I will open from the medial side.
Very good, because you need to find where the nerve is before you do anything at all. Okay?
Yes,
so once you know that there is no neurology and you open it from the medial side, you will reduce the fracture, and then you will hold it with one wire from the lateral side, and you can put one wire from the medial side and then check it on an x-ray. But these are difficult fractures because there's no periosteum left. So if you had a vascular problem and you reduced it and the vessels came back, what are you going to do next?
If distal pulses will come back.
Yes.
I will check this in the 90-degree position. If it's fine, then we'll give a splint.
So how long do you need to have lack of blood supply for compartment syndrome to happen? What is reperfusion injury?
Sir, after
so all the children who have vascular element of some form or the sort, even once you reduce this and have a good result, you will do a prophylactic fasciectomy for them because they have a high risk of compartment syndrome from reperfusion injury. Okay, very high risk. Okay, so you must say that to the examiner that, you know, I will have a very low threshold of doing a fasciectomy because they have a high risk of compartment syndrome. Yeah.
So what's the time you said? 12 months.
There's no time limit. If you have a vascular injury and the hand is pulseless and you have to reduce it, once you reduce it, there are two things will happen. The blood supply will come back or will not come back. If it comes back, it's dangerous because you have a reperfusion injury. And if it doesn't come back, then you have lack of blood supply and will cause compartment syndrome in both cases. So there is a very low threshold of these highly displaced fractures in children if that you need to do a prophylactic fasciectomy for them for preventing compartment syndrome. It's nice to have scars, but it's not nice to have a workman ischemic contracture hand afterwards. Like, okay, how would you know that the hand has had a compartment syndrome in the past, even if it's a mild one? How would you know?
It may have contractures of the long.
That's when it's severe, isn't it? A mild one, passive tenodesis. So if you flex, can you see my hand? If you flex the wrist, the fingers extend. Can you see that?
Yes, sir.
Yeah. And if you extend your wrist, the fingers flex. This is called passive tenodesis, right? Okay. This phenomenon is lost if you have a mild or moderate type of compartment syndrome. The muscles are taut. They don't have the contractures, but they don't do this passive tenodesis effect. So in extension, the fingers don't flex, and in flexion, the fingers don't extend. That means you have missed the compartment syndrome of mild or moderate type in the patient.
And on what basis we will decide to do the prophylactic fasciotomy?
So there is no basis. It is on your own judgment. If you feel that there is going to be a potential of reperfusion injury, but if you have anything longer than 6 hours with no blood supply to it, you have capillary fill gone and the vessels have not been palpable, then you have to do a fasciectomy. 6 hours.
I want to share the case. 3 days back, a kid came, 10-year kid came in our emergency ER of AKU with 10 hours passed, and he had a supracondylar 3 fracture, got extension type. So we took him to the OR, taking the vascular surgery on board, and once we reduced it, their pulses is still not it was they were monophasic. Then vascular surgery explored the fracture, explored the side from the medial side, and the vessel was kinked. It was destroyed. So they did the reverse saphenous vein graft at the same side.
And they did a fasciectomy.
Yes, they did the reverse saphenous vein graft.
Yeah, it was long. This is quite a long time. This is not normal. Normally, the trials are almost always done the very next day by the latest time. You know, most of the time, most of our children come here in this country at about 3 or 4 o'clock, and we try to do them before 8 o'clock at night. If we can't do it before 8 o'clock at night, then we do it first thing next morning. So that's okay. That's acceptable. Anything beyond that, you may have to do a fasciectomy because they may have problems. Yeah. Okay, one more. Okay, you guys need to be a bit more. Maybe do a nice one. Yeah, what about this one then? Who's next? Nobody wants to have a go at this. It's the easiest of the whole ones I've done you show so far.
Yes, sir.
Go on then.
Sir, Dr. Asad.
Yeah, good. But where are you from?
From Civil Hospital, Karachi, sir.
So I don't have many. I know a lot of people in Jinnah, but I don't know many people in Civil Hospital. Go on then.
Yes, sir. Dr. Asad and Dr. Rafiq are from Civil Hospital.
Okay. So go on then. Have a look at this. What do you think?
Yes, sir. Sir, this is the X-ray showing elbow dislocation.
Yeah.
And another gross view showing large wound.
So it's an open dislocation of an elbow,
yes,
yeah?
Sir. Yes, sir.
What type of dislocation is this?
Sir, it is posterior, and I don't know about the lateral or not.
It's only a posterior dislocation. Yeah, I don't have
Yes,
more
sir, it
pictures
is
of it. Yeah, this is just for example purposes. So it's a posterior dislocated
Yes, sir.
open elbow. What are you going to do this? How are you going to manage this?
Sir, considering it, the patient has been ATLS triaged,
Very good.
and this is an isolated injury.
Okay, so there is no
yes,
nerve or vessel injury, but it is dislocated. It's an open injury. Yeah. So what are you going to do now?
Yes, sir. Sir, I will give antibiotic and tetanus prophylaxis.
Okay. Before you do that, what are you going to do?
Clinical photograph.
Yeah, you must always take a clinical photograph. Why?
Yes, sir.
Why do you want to take a clinical photograph?
For medical legal purpose.
Not always.
For okay, so for record purpose.
So what happens is that every time your boss comes in or a senior person comes in, he wants to look. So he will keep taking the dressing down, and that will contaminate it. So once you've cleaned and tidied it up and you've taken a picture, you can show them the picture rather than showing them, the wound all the time. So it is to stop contamination. Yeah. So you will take a picture, take a swab, make sure there is the tetanus prophylaxis are all in up to date. You start with an antibiotic, and then you prepare for theaters for this person to go to theater. And while we're waiting for theater, you need to put him in a back slab. Okay.
Yes, sir.
What are you going to do in theater?
Sir, I will have to debride it thoroughly.
Okay.
And will wash the this bone ends, and then we'll reduce it.
Okay, so you will put it into a Gastillo classification after you debride it, so you will know whether it's a 2, which type of 2 it is, whether it's a 3A or something like that. Once you've done that, you will reduce it. Then what? You've reduced it successfully, and it is unstable. What now?
Sir, if it is unstable, then we will have to reconstruct the lateral collateral ligaments.
So why do you want to say lateral collateral? Why can't you say you have to reconstruct the collateral ligaments? Yeah, because the medial ligament is important and the lateral ulnar collateral ligament is important. Why can't you just say that you have to possibly reconstruct, but not at this sitting? What are you going to do at this? But not everybody is an elbow surgeon, isn't it? I mean, I do upper limb work, so when patient like these comes in, they're clean, tidied up, and they're never put in plaster because you can always dislocate back into plaster. And I see them the next day in a couple of days' time. I sort him out and do the collateral reconstruction with the patient self down. But in the meantime, what can we do? We've already discussed this. What are we going to do?
But should it be first stabilized if it is unstable with the help of external fixator?
Yeah, what is that called? We just discussed this.
Hinge external fixator.
You span it. Span it. You will then scan it, and then you will then plan it. Okay. These are 3 words you have to remember with every open injury you see. Okay.
Yes, sir.
You're absolutely correct. You will put an external fixator on this to hold it. You will clean and debride it. But for the exam, you will say that you will span this to make it stable. You will also then have time to scan it. And once you've scanned it and it's become stable, then you can plan it and you can come back and do the operation with this person, what needs, which means you're getting an upper limb surgeon to come and do collateral ligament reconstruction with this person. Okay? So,
yes, sir.
Good, very good. Now, so you've done this, isn't it? When are you going to operate on this patient? So he's coming today. He has this only injury. Nothing else is wrong with him. And you've taken him to theater, you've cleaned and tidied him up, and you put an external fixator on it, and you find out he's got collateral ligament injury. So your plan now is to reconstruct the collateral ligament. When are you going to do this second operation for him?
Within 48 hours.
Where is it written it's got to be 48 hours?
Sir,
Pakistan wali baat hai na, chhodne wali baat hai. Kitab se proof bata hai.
No, sir, Campbell. Sir, this was mentioned in Campbell. I read it somewhere.
Correct. So you must understand the ebb and flow phase. There is a Cuthbertson model. जब हम physiology पढ़ रहे थे ना, तो Cuthbertson का model था जब इंसान को चोट लगती है ना, तो पुराने ज़माने में जब हम Stone Age में रहते थे, तो हम उस जगह से भागते थे. Every time, flight, fright, fight mechanism, right? उसमें क्या होता था कि हमारे body में जो कुछ भी था ना, वो सब convert होता था glucose में to give us energy. It was called protein होता था, वो भी glucose में convert होता था, fat भी glucose में convert होता था ताकि आप वहाँ से भाग जाए. उसको Cuthbertson model में कहते हैं F phase. उसका मतलब यह है कि सारे आपका endocrine mechanism और सब हार्मोन mechanism जो है ना वो totally upset है and you're just trying to make glucose. So when are you going to operate on this person? You're going to operate on this person in the flow phase. In the flow phase, जब सब कुछ सारा ठीक हो जाता है. Flow phase का मतलब यह है कि प्रोटीन ने अब ग्लूकोज बनाना बंद कर दिया है. It is not making protein. You will do the urine test, and the urine tells you hydroxyproline उसमें नहीं है. इसका मतलब है कि वो पेशेंट जो है ना, वो पर्सन अब फ्लो फेज. ठीक है. इसका मतलब यह है कि नॉर्मली जो है ना 4 से 6 दिन लगते हैं. But सिर्फ कहना कि 4 से 6 दिन, and to understand why you're doing it, that's the difference between you as an FCPS candidate and somebody who is just a medical student. Like, okay, so you have to have a reason why you want to do it and when you want to do it. तो एग्जामिनर को बताना है कि इस वक्त जो है ना एप फेज में है, जब वो फ्लो फेज में चला जाएगा और प्रोटीन ग्लूकोज में कन्वर्ट होना बंद हो जाएगा, वो स्टेबल हो जाएगा. इसको कहते हैं सेकंड हिट थ्योरी. जैसे वो आपको अगर याद है 9/11 में जब पहला जहाज गया था उसने बिल्डिंग नहीं गिराई थी, जब दूसरा जहाज गया था तो बिल्डिंग गिरा दी. तो इसी तरीके से अगर आपको सर्जरी हुई है या ट्रॉमा हुआ है ना, तो पहली से आपको हिट हो गई है, अब आप उसको विद इन जो है ना उसके एफ फेज में उसको दोबारा ट्रॉमा देंगे ना, तो वो फिर पेशेंट जो है ना वो मॉड सर्ज उसमें चला जाएगा, मल्टीपल ऑर्गन डिसफंक्शन सिंड्रोम और सिस्टमिक इन्फ्लेमेटरी रिस्पांस. सो एज एन ऑर्थोपेडिक सर्जन हम लोग को बोन जोड़ना भी आना चाहिए, बट बंदे को जिंदा होना चाहिए ताकि उसकी बोन बाद में काम करे. यू नीड टू ऑल दिस फिजियोलॉजी, एंड दैट्स व्हाई यू डू एग्जाम्स. यू डू एग्जाम्स टू नो व्हाई यू डूइंग एवरीथिंग rather than just going and doing a DHS and a Hemi and all these kind of things. Exams are to make you a better person. Okay?
Yes,
so, exam में जब भी open fractures देखें, ever, आप उसको कहेंगे कि ATLS triage करने के बाद assuming this is an isolated injury. पहली बात. दूसरी बात ये है कि हर चीज में आपको कहना है कि मैं इसको span करूंगा, फिर उसके बाद जिसको मैं scan करूंगा, फिर मैं plan करूंगा, especially in open fractures. उसकी reason ये है कि you want to prevent the systemic theory, and you also want to do what is called damage control orthopedics. Okay? बंदे को नुकसान नहीं पहुंचाना है. You know, you have to put him into a normal function again. Okay? Let's find a nice one. One more nice one. Let's get out of this one. Yeah, this is a nice one actually. If you do this, I'll be very happy. Anybody who wants to go, I'm quite happy for anybody to do it. But if you tell me rightly what this is, I'll be very happy. I'll be delighted actually if you tell me this. I've even shown an arrow to tell you what's happening.
It's corner fracture.
Very good. What is it? What's a corner fracture?
Sir, so battered baby syndrome in child abuse.
Very good. आज आपने सबने मेरा दिन बना दिया. It's called non-accidental injury. Okay.
Non-accidental injury. Yes.
Exactly. How will you know that this is a non-accidental injury?
Sir, I will take a history and physical examination.
But इसके बाप तो माँ तो नहीं बताएगी कि मैं इसकी फैंटी लगाता हूँ. So how will you diagnose a non-accidental injury?
I will look for other injuries.
Very good. You will look for concurrent injuries, and you will look for injuries with multiple dates and ages. So, कोई injury जो होगी वो 10 दिन पुरानी होगी जिसमें कैलस बन रहा होगा. कोई injury जो है fresh होगी, कोई injury जो है already heal हो चुकी होगी. ठीक है. Multiple areas में fractures होंगे. एक common law है, rule है, वो ये है कि non-working baby जो है ना उसकी long bones का fractures नहीं होता है.
Oh yes sir.
ठीक है. So you are as guilty as the parents are if you send the baby back to the same environment with a non-accidental injuries. So you cannot.
I will report to the Child Protection Society.
Exactly. You can't miss a non-accidental injury. जो rib fractures होते हैं ना बच्चों में नहीं होते हैं. अगर बच्चों में देखो, you can see there are healing fractures of different types. So yes. This is a non-accidental injury. What test are you going to do for a non-accidental suspicious injury? What are you going to do?
Skeletal survey.
Very good. You have to do a skeletal survey. Okay. उसमें जो है ना long bones, ribs के, skull के fractures करते हैं. ठीक है. ये last करते हैं because I've got to go somewhere then. So have a look at this. What do you think this is?
Galeazzi, sir.
Very good. So what does Galeazzi tell you?
Sir, Galeazzi differentiates the shortening between the either it is in the femur or in the tibia.
Okay, so it can be anywhere between the above the knee or below the knee. Okay, so you need to look from the front and you look from the side. Front से जो है आपको femur पता चलेगा, side से देखेंगे तो tibia का पता चलेगा. ठीक है. एक और sign होता है बंदों में जिसमें dysplastic hip होता है. एक तो Galeazzi sign होता है, दूसरा क्या होता है sign जिसमें
telescoping
होती है, एक और चीज होती है. मल्टीपल
dislocation.
वो होते हैं folds, skin folds होते हैं different.
Asymmetrical gluteal and
Very
thigh
good
folds.
sir, very good. आज सबने जो है ना पढ़ के आए हुए यहाँ से लगता है, या जो है पिछली दफा से आज बहुत बेहतर है. बट यही मेरा कहने का मकसद ये होता है ना, the more you sit down, the more you discuss, the easier it is for you to pass exams. मतलब मेरे को तो ऐसा नहीं, लेकिन आप लोग का भला ही होता है कि इसको पार्टिसिपेट करें. मतलब मिलते करके लोगों को जमा करूं, ये तो दिस इज नॉट माय जॉब. गुड, वेरी गुड. इसको नेक्स्ट टाइम करेंगे बाद में पिच में. तो आई जस्ट वांट टू शो यू दैट मल्टीपल फोल्ड्स थिंग. इफ देयर इज समवेयर आई कैन शो यू, एंड देन वी विल कॉल इट अ डे. या Yeah, this is what it looks like. जो dysplastic या dislocated के hip होते हैं ना बच्चों के, एक तो उनकी leg short होती है तो उसमें गलियां दिखता है, दूसरे में multiple folds होते हैं. These are classic features of dysplastic hips. Okay, dysplastic या dislocated hips जिसको कहते हैं. ठीक है. Okay. So मेरा पूरा weekend फारिग होता है. I can do teachings on weekends, but if I have to do it on weekdays, week में करेंगे, लेकिन evening में करेंगे बाद में, फिर इसी time पे. Okay.
Sir, we are ready.
Okay, sir.
Okay, but I'm happy today. आज सब लोगों ने बहुत अच्छा किया. Very well done. Very well done. Good.
हम तो यही चाहेंगे कि आप डेली हमें प्रैक्टिस करवाएं.
मैं तो नौकरी भी करता हूँ, तनख्वाह भी कमाता हूँ, बच्चों को भी खिलाता पढ़ाता हूँ. मेरे पास ना टाइम जो है वो जिस दिन मिलेगा मैं जरूर शेयर करूंगा पर आपके लिए.
Sir, basically whatever you are doing for us is not less than a blessing.
Sorry?
Sir, YouTube पे आ जाएगा.
Whatever you are doing for us is not less than a blessing.
No, I've been teaching for 4 years now. आप लोग को सिर्फ नहीं पढ़ा रहा हूँ, मैं पिछले 4 साल से पढ़ा रहा हूँ, लेकिन ये कि आप लोग पार्टिसिपेट करोगे तो मुझे भी खुशी होती है ना. मैं इधर खड़ा होता हूँ, अगले 2 बंदे सिर्फ बैठे होते हैं तो हम भी जो मक्खियाँ मार रहे होते हैं जिसमें कहते हैं.
बराबर शब्द और लेक्चर देते हैं.
Okay, good.
Thank you.
See you soon, inshallah.